Welcome to the March 4th Addiction Toxicology Case Conference brought to you by the American College of Medical Toxicology and the American Society of Medicine. This is a webinar brought to you by the two groups as webinar partners. Please see the acmt.net Addiction Tox Case Conference FAQs that were supported by a grant through the Opioid Response Network and SAMHSA in 2020 and 2021. I'm Tim Wiegand, Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester in Rochester, New York, and Dr. Gloria Bashevitz, Medical Director of Strong Recovery and Professor of Clinical Psychiatry in the Department of Psychiatry at the University of Rochester in Rochester, New York, is my co-moderator. And we have some panelists, expert panelists, friends and colleagues from the U of R. Anne-Marie DeSantis is a guest expert. She's a nurse, neuroresilience, pain management nurse, and in the Neuromedicine Pain Division, Department of Neurosurgery, University of Rochester, Rochester, New York. Dr. Robert Horowitz is the Chief, the Palliative Care Division, Department of Medicine, University of Rochester, Rochester, New York, and Dr. Anna Kenny, Assistant Professor in the Department of Medicine, Palliative Care at the University of Rochester in Rochester, New York. None of us have conflicts of interest to disclose, and I'll let Dr. Horowitz share his slides. So go ahead, Rob.
Okay, Tim, if you will unshare, I'll share. Here I go. All right. Oh, okay. See that okay?
You're all good.
Okay, good. So I should say, Tim and Anna and others of us who came up with this title, Who Cares? It might sound rather crass. It is a reality in this space of the stigma around substance use disorder. That's not an unusual comment to be either said explicitly or felt or assumed. Who cares? There's addiction at play. It also means who cares? Who takes care of these patients? And so we're going to start with a case that I know well. I'm calling him Sal. It's a patient with pancreatic cancer. And the question is, who cares for his total pain? By which I mean the different kinds of pains he has, the pain related to the cancer and the pain of the suffering that precipitated and fueled the addiction in the first place. We know any little bits about that, and how do we do it? So I have a timeline on the left, and this is really a 3-month saga from last year. It's from 2021. And I want to tell you a little bit about Sal and how he came into our care. The consult came to us with this pain management, newly diagnosed pancreatic cancer and heroin addiction. Whether knowing that it's heroin addiction or not is important. Tim, you raised a question as we were preparing this. How does that affect us as we're walking into a consultation? And it certainly puts us on notice in some way. It might be useful information. It might also be a bias that gets in our way. We can explore that later if you want. Sal presented to the emergency department with 2 weeks of epigastric pain, a 20-pound weight loss. His CT showed an advanced malignancy, widely metastatic through the peritoneum and the liver. He had a biopsy. It showed adenocarcinoma. And so he was diagnosed with stage 4 adenocarcinoma of the pancreas. He had no substantial past medical history in his chart. He was on no medications routinely. He's 60 years old, self-employed contractor. He lives with his wife, Mary, who herself is in treatment for stage 4 non-small cell lung cancer. Talk about tragedy upon tragedy. We know he's the father of an adult daughter. We don't know a lot of detail, but we do know that his daughter left his life 15 years ago, and it was related to his lifestyle. It was related to his addiction. It was related to her anger at his absence. He's been in recovery from heroin use disorder, which was intranasal and IV at some point since 2014. He was on methadone at one point, maxed at 90 milligrams, was stabilized on 70 milligrams a day, and then lost to follow-up 2 years before he presented to us. We know that he had tried buprenorphine. He shared this with us, and we believe he had precipitated withdrawal when he tried buprenorphine on the street and had a miserable experience and said, no effing way am I ever going to try that again. He outright rejected ever to use it, if ever it came up, and it came up in our conversations many times. We know his current use of heroin, I put in quotes, heroin, snorting 4 bags a day for his pain. And he made clear this is for his pain. He was well familiar with being stigmatized and the liability therein. He had been sober for some time on the methadone, then off the methadone, his story went, but he resumed the heroin because the pain was just unbearable. So you know, the question is, who cares for Sal? He's in the hospital. He's in the cancer center. I'm one of several people being consulted to see him. Tim, I don't know if you want to take it from here for a moment or just proceed ahead. I'll follow your lead.
Yeah, there's some good questions. I'd like to just go back to the buprenorphine just for a second. I mean, I think you mentioned the context of him trying that on the streets, and certainly would be something that I would approach, you know, as an option, but not as the only option for pain control, because then, you know, I'm thinking, you know, the consult is, you know, a gentleman with this pain and diagnosis and also heroin addiction. So how is that important? I agree it can impact in a very stigmatized way. As the patient is certainly focused on, you know, if they're treating me like I have the heroin addiction, it's going to impact pain control and all sorts of things potentially, as well as bias and stigma. But at the same time, we have to understand, you know, there's tolerance, dependence, you know, and dose medications appropriately for that. One of the things, you know, if you try buprenorphine in, you know, the current climate, heroin essentially in the Northeast and many parts of the United States, as well as North America, is adulterated with fentanyl. And fentanyl is very different than traditional heroin. So if not started with like something like a microinduction, I would expect that he would have precipitated withdrawal. So that, you know, maybe something worth exploring, you know, in more detail. Although it does seem that he had a good experience with methadone, and you know, that probably would be the default. But for somebody that, you know, may not have had an experience with methadone or considering, you know, what type of pain control, I'm considering, well, he's got to also treat this dependence and withdrawal at the same time as treating pain. And I often see full agonists not ideally suited for all of those goals. Methadone potentially better, but not, you know, other full agonists. I don't know if you have any other thoughts, or Dr. Bishevitz wants to comment. Dr. Kinney.
No, I agree with those options, Tim.
Okay. Dr. Horowitz, have you had patients coming in where they've been on buprenorphine and, you know, it's been effective, and you're able to leverage, you know, other opioids on top?
Yes, yeah, no, absolutely. So somebody who is in a stable sobriety, or maybe not even a stable one, but is using the buprenorphine, that's a fine thing to retain. Of course, it requires then, when we're treating the pain, to use often far more generous doses of full agonists than we might otherwise. But certainly we've had folks who came in recovery, committed to their recovery, and looking for help with the pain, and that gets really complicated in a different way, for sure.
Right.
Yeah.
Yeah, I think we can continue on.
Okay.
Thank you.
Well, so I'll proceed now. So the question of, you know, who cares for Sal, it really comes down in a way to what are his care goals. And I share this with you. It's a way we think about serious illness conversations, ensuring that the medical situation is well understood, what's going on, what are the prognoses of the illness, meaning lifespan prognosis, symptom prognosis, cognitive prognosis, what treatment options are on the table. And then given that, what are your values? What matters to you, your priorities, your hopes, your worries, your preferences? And out of that then can come a plan that makes sense for this person in the context of what's going on. So for Sal, the medical situation is he has incurable disease, and he absolutely got that. He understood that his prognosis was 2 to 6 months. The 6 is generous, but could be without treatment. He had lost substantial weight. So in addition to stage 4 pancreatic cancer, he had been losing weight, had a difficult time eating. So functionally, he was declining. So towards the lower end of that wouldn't be a surprise. Potentially, that could be extended with treatment. It would carry with it some consequences, some side effects. And his values, you know, here I'm being kind. He was a fiery, individual, and he spoke his mind without any hesitation. And he didn't want any effing chemo. And he wanted to be clear that he wanted to be at home, not in the hospital. And he wanted to be at peace. He talked about that a lot. I want to be at peace with less pain until I die. So given that, his plan is clear. He does not want resuscitation. He doesn't want to be intubated. He doesn't want a feeding tube, for goodness sake. That was straightforward. He wants a symptom-focused treatment plan focusing on being at peace, being at less pain, and being at home. And so that was going to comprise medications to treat his symptoms and procedures. We'll talk more about celiac plexus block, if it could work, radiation therapy potentially, home hospice evaluation after the procedures were complete. And so the question of who cares for Sal, in his case, it became us. Palliative care were going to be the, in our language, hub of the wheel in his medical care. And radiation oncology and acute pain would be spokes of the wheel. I should say that Tim and Gloria are often sort of a spoke, sometimes an unspoken spoke, in the background. We talk with one another, not infrequently in the hall or otherwise, to get support for one another as we're thinking things forward. So there are big spokes and small spokes, and you guys are big and sometimes quiet spokes, but really important to us. So it raises some questions. Tim, I'll let you take it from here and ask your questions, and I've got some thoughts.
Sure, and there's a couple of questions and comments in the chat that I just want to bring up as a reference to a cartoon about stigma and opioid use disorder from someone that's a link. And we have a comment: I would look at his life expectancy and consider methadone split 3 times a day with another opiate for breakthrough, and possibly duloxetine for pain and depression. So looking at some non-opioid agents. And the comment: it's true that he falls in between medical disciplines. And then there's another comment. There's someone from Canada. What about offering a macro induction of buprenorphine? We have some Canadian colleagues doing ED 16, 8, and 8 Q1 hour for a total of 32 milligrams over 3 hours. And I just want to comment a little bit about that. The macro inductions, I think, can be really a disaster if the patient isn't already in severe withdrawal. If the patient has opioids in him, the risk of precipitated withdrawal increases by the dose of buprenorphine or naloxone compared to the time that's elapsed from the full agonist and how much full agonist is here. And assuming this gentleman has fentanyl in from protracted use, he's going to have a lot in his lipids. And I think that the macro induction is really taken out of consideration. It's only appropriate after someone has had precipitated withdrawal, so getting them back out of withdrawal. I really wouldn't think it had to have a role here at this point, and really already they've decided on use of methadone. He's had a bad experience with the buprenorphine. So Dr. Bishevitz, you're nodding your head?
Well, sure. And of course, like you say, patient choice is paramount here. He's the one who has the very severe prognosis, and he's choosing methadone and instead of buprenorphine. He's had experience with both. It makes perfect sense.
Okay. Then there's a comment, why would you want buprenorphine here? I think that I agree, methadone is probably the most appropriate, but in some individuals that have been on buprenorphine and they've been able to continue, absolutely you can get adequate analgesia when you use the appropriate full agonist on top of the buprenorphine. So the buprenorphine would be for withdrawal dependence and some analgesia, mood stabilization as well, but you would need to add opioids on top and have the opiate sandwich. I want to ask Anne-Marie DeSantis, we've had a lot of talk about some pharmacologic management for pain, and this patient has a lot of stress, and what are some techniques that you could use or recommend or consider in treating his pain, as well as his anxiety, stress about the diagnoses? How might you approach this patient, or what could you offer? Anne-Marie, you're muted, I think.
Yes, I was starting to say that one of the simplest ways to establish trust and connection with a person who is been dealing with substance use disorder for a long time and has either chronic pain or end-of-life pain is to shift from really being focused on physical symptoms, which is crucial. How are we going to manage your pain? That's very important to Sal. But to shift also into from asking what's the matter to what matters to you. And so this model that includes the values, I think you did a really nice job, Rob, of addressing that. I, in looking at the slide, saw that his wife has a very serious illness as well. And so his anxiety about perhaps what will happen to her, who will take care of her once he's gone, is one issue to be able to address and give support around. And then the other question about the estrangement from his daughter, is that something that is heavily on his mind right now? I think that the shame piece that comes to most people with addiction can underlie that angry outburst that you see. And some of that is really from trauma, past experiences of being in the hospital or detox and being treated as an addict. And so to be able to really convey, you are important to me, and what matters to you matters to me. And then there's some, as far as practical tools in the hospital, there's a wonderful meditation called Metta, or loving kindness. Rob, you may be familiar with that from your work or your practice in meditation. But it's really focused on repeating and calming our nervous system, really. May I be safe and secure. May I be peaceful. May I be free from pain. And may I live with ease and contentment. So taking that in, either with someone guiding you in this or listening to a tape, and there's a process where you then send that message out to loved ones and to the world. So those are a few thoughts that come to my mind right now.
That's great. Thank you. Anna, Dr. Kenny, did you want to add anything?
No, I think people have really covered a lot of it, and I think it's good to hear about different ways to cope with pain than medications, because we definitely, in medical school and most healthcare training is, here's a symptom, what pill do we use? And clearly, I know we're going to be talking about more pills, but I think it's always important to look at patients holistically and see, I think also what Dr. Bashevitz talked about of, taking the patient-centered approach of what is his preference in this goes a long way.
Absolutely. There's a comment, and I just want to say more a comment than a question. Sal's case is a very important reminder to us how important it is to be very sensitive in the way that we do teach buprenorphine inductions, as a bad experience can have lasting impressions that are laden with emotions. It is totally reasonable for Sal to reject bupe at this point, but what a shame that this otherwise viable option seems closed off to him. Therefore, let's all remember mindful bupe inductions are not only good medicine, but part of being kind. Yes, certainly. And a couple of other, there are people in recovery who don't, I can't read don't become addicted, again, even with a terminal diagnosis. And then some other references to palliative care and addiction medicine that I think we can share. Dr. Bashevitz, did you have anything that you want to add?
No, I think the path is clear based on the conversation map that we discussed.
Great. Rob, go ahead.
I'll plow forward then. And I should just do a quick shout out. I see Kathleen Broglio out there. There are some palliative care folks who really care about pain and addiction, and I'm glad you're in the audience, Kathleen. You've got a lot of wisdom and experience around this thing. So I just want to say humbly, so we often in palliative care and in pain, we are thinking about equianalgesia when we're switching between opioids. And so this gentleman coming in, I just want to just share with you the thought and then humbly confess I don't have an easy answer to this. Somebody who's using heroin, snorting a bag of heroin, which we know is actually likely fentanyl as well. How are we going to treat his pain? He's here in the hospital. He'd been using a bag at a time to ease the pain, he said. And I also have to recognize, as Anne Marie was saying, I mean, his pain is not just a somatic pain. He is treating the pain of this lesion in his belly. Absolutely. He's also for years been treating all sorts of pains, as people do when they use substances, not just if they're addicted to substances. So his existential pain has been a part of the deal. Can we approach that in the hospital with IV medication? Holy cow, it's tough. So he's having 20/10 pain that is unresponsive to 1 milligram of IV hydromorphone, which would not be an unusual sort of standard starting dose in an opioid naive person, but it is a drop in his bucket. And so here's just some of the thinking. This is something I might do with my medical student. I suppose it makes me look smart, but in fact, I come out of this feeling that God is probably a waste of my time to try to do it, but I'm going to do it here anyways, just to show you. A bag of heroin, and again, I'm guessing, he says it eases the pain from a 12 to a 5, 4 times a day. So what's in that bag? If there's so many ifs here, if a bag is 100 milligrams of heroin, and Tim added this, what about fentanyl? You're right. So if it's 100 milligrams of diacetylmorphine heroin, if that's 50% pure, if IN, intranasal diacetylmorphine, equals tenfold the strength of oral morphine equivalents, then a bag of intranasal heroin might be comparable to 500 milligrams of oral morphine. And this is honestly just guessing. 4 bags a day, that's 2 grams of oral morphine. If it's 20/1 to IV hydromorphone, which he's getting, then we're really talking about somewhere around 100 milligrams of IV hydromorphone a day. If it's 5% fentanyl, just to make it a little bit more complicated, we're probably talking about double that. So 200 milligrams of IV hydromorphone a day, maybe. So what do I do with that? So here's what I do. I say, holy cow, no way am I going to start with 40 milligrams of IV hydromorphone PR, and I'm just not going to do it. It's just because I just don't know. So I'll start low and I'll increase as fast as I can. And that's what we did. From that 1 milligram, it didn't touch him. We gave him 2 milligrams PRN. We gave him 4 milligrams PRN and would have gone up to that. I'm not going to start at 8 or 10 or 20, but I'm going to start and I'm going to give him a generous watch, even though that makes the nurses at the bedside understandably nervous. I will support them in that. He said it does nothing and I'm out of here. And he refused the opportunity to move up to 8 milligrams. And I think he was probably right. We weren't going to land on a dose that was going to work. He did agree, though, to start the methadone again. And, per usual, per teaching from Tim and others, starting at 10 milligrams TID, even though I know he's probably going to end up higher, made sense. We did start at 10 TID. We plan to increase that fairly rapidly, more rapidly than maybe the pharmacokinetics would say. And we referred him for a celiac plexus block, which is a very useful way of easing pancreatic cancer pain. So we're just a few days in, and he did have a celiac plexus block. It was a test block with lidocaine. It was successful. He was thrilled. It lasted briefly. We had radiation therapy in the backdrop, which might help with the pain if needed. And he went home, and we rapidly up titrated his methadone a bit more quickly than you might otherwise, but soon enough we're at 20 milligrams TID, moving up if he wanted, but he was quite pleased, and this is about a week in. Great satisfaction, deep gratitude, and I'm feeling pretty darn good. He went in for then the celiac plexus neurolysis because this is the lasting dose. The first dose is really a test with lidocaine. This next one is with alcohol to really lyse the nerves and give him lasting pain relief. And it didn't work. It didn't work. And 4 days later in the EHR, I got a message and he was pissed and he was angry and he wanted a relief now. He said, I'm suffering, I'm being ignored, I'm being treated inhumanely in your care. It seems to me that since I'm a known addict, I have been blacklisted. He was really mad. I can tell you, oh, go ahead, please.
Question, there's a comment about, or question, would you have checked an EKG and QT interval in this case before starting methadone?
Yeah. And we did, and I will tell you though, in truth, I'm looking at a guy, it's not that I don't care if that he's gonna die soon and so nothing else matters, but if I'm looking at the balance, I would, and I always have a conversation with my folks, mentioning why we're doing the EKG and asking if that's going to have an impact for you. Because the individual risk of a long QT, more than 500, for example, the individual risk is extremely low of having a lethal arrhythmia. But across the group, there may be some risks. So I have that conversation, and I know for him, it wouldn't have stood in the way, and neither would it have for me. I think it makes sense to do for medical legal reasons, but in this guy whose values are clear, I'm going to get him on the methadone, which he wants to be on to stay safe for the duration of his life.
Yeah, those are great comments. I saw Dr. Bashevitz nodding as well. I think that your exercise in equine analgesic was important because there is a vast literature that shows when patients have opioid use disorder, they're underdosed for opioids in the ICU in particular, when sedation regimens and analgesia and many other settings. And so really appreciating the amount of tolerance and dependence that someone may have, and that it's good just to understand that you may need to really get to very high doses to control analgesia, much less keep an individual out of withdrawal. So, it's not a perfect a science, and certainly your point of starting low and titrating up is very reasonable. And I think, that's, one of the reasons when I do have patients where buprenorphine is appropriate, I really like the buprenorphine. It's great at keeping people out of withdrawal. And treating the dependence and some analgesia, and then the full agonist on top. And this patient, the methadone, also served that purpose and seemed to work. So yeah, I think a very good exercise. The heroin in the Northeast, from what I've seen from Crime Lab and other things, is about 5% fentanyl, and sometimes has other stuff, xylazine. So there may be other agents this individual is also dependent to that he's not even maybe aware of. About 30% of the heroin in the Northeast now has the horse anesthetic xylazine. So there may be other reasons to consider, the substance use. Dr. Bashevitz, you're nodding. Did you have any other comments that you wanted to?
No, but I think I want to comment at some point that the question often comes up, well, should he go back to a methadone clinic? I mean, clearly this guy seems too sick to go to a methadone clinic right now. But one of the reasons that we really recommend palliative care give the methadone at this point in care is if the person ever needs to be in an SNF, say for example, if the person had started out in a methadone clinic and developed a terminal cancer, and then if the person needed to be in an SNF, it's a lot easier to get someone into a skilled nursing facility if the medication is prescribed for pain by palliative care rather than for addiction problems by us in methadone maintenance.
Yeah, good point.
Also, just a question about xylazine. Xylazine is a increasingly common adulterant that had been common in Puerto Rico. It's a veterinary anesthetic, and it's used to potentiate the opioid effect, to increase it. It is somewhat like clonidine in terms of the effects. So you have sympatholytic as well as a little bit dissociative effects. So it's basically somebody using regularly will have more severe withdrawal and potentially not just respond to opioids as well. They're also at greater risk for overdose. If those of us in Rochester remember in the summer, the cluster of fatal overdoses, all in one house, that it's xylazine adulterated heroin. So that's something to be aware of. Drug supply is more dangerous and adulterated than ever before. So let's get back to the case.
Yeah. So he called back. He apologized for being gruff. This is the nature of him. This is his nature. This is also, just to state, I want to be cautious about characterizing all people with addiction, but the drive for urgent response, for immediate relief is part of his character, and that's something we had to grapple with. And so it was a bit of an emotional roller coaster, our relationship. He was very frank with me. I was very frank with him. He apologized for lashing out. The palliative care team continued caring for him. We encouraged patients with a neurolysis. It can take up to 14 days to help. We added Decadron to help with potential inflammatory pain. We added a PPI, sucralfate, a gastric protection, because he may well have had some gastric irritation, if not ulcer. 3 days later, he reported relief again. for at least a few days. But then just a week later, he had increasing moderate pain. It was 7 to 9/10, which many people would call an emergency, but he let us know it's sure better than 20/10. He did the radiation therapy over 2 weeks in early May. And then he had another acute pain flare, which can happen after radiation. We admitted him to the hospital. He rejected a trial of IV ketamine at this point. We'll talk more about ketamine momentarily. He agreed, though, to go home. We up-titrated the methadone now for pain and opioid use disorder. We're getting dual purpose here, 30 milligrams TID, which is pretty good for a pain dose. We're not going to get much more bang for our buck as we go up that dose response now plateau. He did agree to trial oral ketamine for numbers of reasons, which if we have time, we can talk about, but it certainly can be useful. It certainly has some kappa antagonism, NMDA antagonism. It may be useful in all sorts of ways in easing the suffering from pain, not just because of mitigation of somatic pain, but because of the other sort of relational experience of pain. We added some oral hydromorphone with a max. We were going to give him a trial of that. I know somebody in the comments suggested that. Of course, getting some PRN opioids can be helpful. He had a few good weeks, stopped the oral ketamine because it wasn't helping. And this is the medication he was on. We did add gabapentin, by the way, along the way. And he was feeling pretty darn miserable and said, it's gotten to a point that I've given up. I can tell I'm dying. I'm weak. I need help. He had lost 30 more pounds, down from 225 to 175 over the course of 3 months. The hydromorphone was not helping his pain. It was making him sleepy, but it wasn't easing his pain. And his urine screen showed methadone, hydromorphone. It showed a surprise, THC and alprazolam, things he hadn't reported. And he asked us for a pain pump. A few questions. And also, Tim, honestly, I want to be aware of time and that there's another case coming. So you guide me how to move forward, because I can jump to the chase if you want.
Yeah, no, I think that you can maybe comment on these in your perspective. There's some comments that I think you addressed in the chat coming up. So keep going.
Okay. Yeah. A question about the pain pump. A pain pump can be very useful. A PCA can be very useful for pain. We like to think of it as a relatively short-term option for folks just post-operatively or with an acute pain flare. We like to know that there's proof of concept. Somebody who says, I take the hydromorphone and all I do is get sleepy, I'm not going to think a pain pump is going to likely be useful. It's going to give more of the same, odds are. Plus, there is a reality of managing it logistically. The reality of his addiction is not a primary hesitancy for me, particularly in somebody who's clearly getting sicker. But if I'm talking about months or years at home with IV access and a pain pump, I'm going to be really cautious in any patient. We had some other thoughts about how to treat the pain. I will say, in fact, I'll move forward. I see a comment about it. The surprise alprazolam and THC, honestly, we just had a discussion about it. And I simply asked my folks to be honest with me to the extent they're willing. It did not change the course of things. We moved forward. And because he didn't want to be in the jail of the hospital again, because he did not want another celiac block. That second one really hurt. It is a horribly uncomfortable thing to put up with, having those needles thrust through his back to try to get to the celiac plexus. He agreed to try an opioid switch. So if he's not responding to methadone and hydromorphone, trying a different opioid, which has a similar but different, particularly a synthetic opioid like fentanyl, made sense. We tried 100 mics, then 200, then 300 mics an hour. And he reported excellent relief for a few days. And then he said, I'm so weak, I can't stop throwing up. I can't even move. I need help. And he agreed to be admitted to the hospital. And these were his last days. He came to our palliative care unit. We kept him on the fentanyl, which he was on. That's comparable to probably something around 1 gram of oral morphine a day. Comparable maybe to the amount of methadone he was on. It's impossible to know really in any individual if these switches really are equal. He remained on the dexamethasone. He was on a hydromorphone PCA at that point. We agreed whatever it took to help him feel more comfortable, and he pushed that an awful lot but wasn't getting relief. We started ketamine. Ketamine can be very useful both for treating pain in people with high dose opioids. And some of what are called its side effects, its adverse effects, so-called hallucinations and dissociation, actually, if you know about ketamine-assisted psychotherapy, it's actually useful. It's actually a goal. And if we name the reality that you are likely to feel different in your body, that the way you experience your pain and your suffering is likely to change, and be open to that, it's amazing what might happen. And what happened for him is at 0.2 mg per kg per hour, these are way sub-anesthetic doses. He was sleepy, he was calm. At 0.3, he was sleepy, his pain was uncontrolled. He was pushing that button a lot. And I should say, I call this habit push. Those PCA buttons shouldn't be green, they should be yellow, because green means go. And he said the same, especially when he was kind of bleary-eyed. He saw the thing turn green, he pushed the button, he got sleepier, but didn't have much pain relief. When he hit 0.5 mg per kg per hour, which is often a goal, will sometimes go as high as a mg per kg per hour, he was lethargic, he was peaceful, and he had no pain, and he had no fear, and he was feeling grateful. And Anne-Marie, that is the time, a little bit before that, we were talking about his daughter who had, we couldn't locate. We did get in touch with his brother, whom he was estranged from, and he had, through us, he did not want to talk with his brother, but through us, he had a conversation, and they made some peace. They'd had a long, strugglesome relationship. At this dose, Sal found some ease, and he was so clear one morning and so comfortable. We said, let's bring down the dose and see what happens off of it. And we tapered the ketamine, and we stopped the hydromorphone because he wasn't needing it, and he stayed feeling very well, very peaceful. And then he went to sleep, and he died. And that was the end of Sal's story.
Thank you, Rob. That's really remarkable. You know, I think, and really handled well. I just have a couple. I know we have the second case, and I think we'll have enough time. We have. I had a couple of questions just about the initial fentanyl patch and the up titration. One was, do you think some of his nausea initially, after he had a good effect, was, you know, the accumulation of fentanyl, and then he, you know, may have gotten used to it, or just, it's hard to say.
Yeah,
Probably hard to say.
right. It really is. You know, odds are he was at the very beginning, he was snorting, you know, fentanyl and heroin and who knows what else. So I think he certainly had some tolerance at that point. So I don't know if the 100 mics, ultimately the 300 mics per hour he was getting from us was substantially more than his body had been used to just months earlier, but I don't know. It's a great question.
And Anne-Marie, as a former hospice nurse as well, and, you know, working in pain, you, in particular, as he's approaching an end of life, and Dr. Horowitz mentioned some of the, you know, considerations as well, but, you know, do you have any other thoughts or comments where you would add to the end of life care ideally?
Well, I just want to say I find this case very moving, especially as to the outcome. And I think it really speaks to the importance, certainly of the medical management, but also that personal connection, trust, and compassion that you brought to the bedside that led. As a hospice nurse, I'll just say this, that in central Vermont, rural Vermont, where I practiced for a number of years, going out often in the middle of the night to patients who were in unrelieved pain or high anxiety, trouble breathing, I actually found using guided imagery often just as effective, if not more, than several doses of lorazepam. And also integrated imagery, which is inviting the patient to use their own images of peace or a safe place and so on. So, and that's something that you can learn to do very easily if you're not familiar with how to guide. I think that a breathing practice, even at end of life, can be really useful, helping people to learn to focus on their own ability to self-manage the fear and calm that amygdala-related threat anxiety response.
Yeah, those are great comments. Thank you. Dr. Bashevitz, do you have anything else? I know, Dr. Kenny, you're going to start the second case, but any other final comments?
No, that was a great case and many good issues.
Okay, go ahead. Thank you, Dr. Horwitz. Go ahead, Dr. Penny.
All right, and just want to make sure, are you seeing the presenter view or normal? You see my whole slide?
Yeah, you're good, Anna.
Yep.
Great. All right, so we'll move on to the next case, if it will move forward. So I'm Dr. Anna Kenny, a palliative care physician here at Strong in Rochester, New York. And my case is also involving a patient facing addiction and a question about who should manage methadone, which came up in the earlier case as well. So just to give you an idea of the information we got, so I was on the consult service and was told about this gentleman who had an upper GI bleed, concern for metastatic pancreatic cancer. He wants everything done so far, and he's been started on the methadone while he was in the ICU. The consulting team wasn't really sure whether we were using methadone right now for pain or opioid withdrawal or both, and they wanted us to consider taking over the methadone as an outpatient. So a lot of words on this slide, but basically to give you kind of an idea for my patient, who we'll call Jim, 64-year-old guy, and he has a history notable for polysubstance use, using intranasal heroin, alcohol in the past. He also has sleep apnea and Hep C that's been successfully treated. He's had chronic pain and disability for several years. He also had this pancreatic mass that was found a couple months ago, very suspicious for malignancy, and has been stented. And he came in a couple months after finding that mass with abdominal pain, eventually had hematemesis, so throwing up blood, as well as hemorrhagic shock, and some concern for some local perforation of his intestines from the mass. So the next day after admission, he actually had been doing okay that first day until he started throwing up blood, was intubated for airway protection. The next day after that, got extubated, and during this whole thing got exposed to COVID. So was on isolation. And then briefly just social, he lives alone, has several friends, is a veteran. And I'll be honest, I didn't get a chance to really learn that much about his social history, but I did know that he had a cousin who was this out-of-state emergency contact for several years and had no local family. He's practicing Muslim, which we did talk about. In terms of labs that were pertinent for me, he had an EKG with QT of 454. His creatinine was his baseline, and pretty low hemoglobin. And this is, I think, right before he got another transfusion. And so, yeah, part of our consult was also for pain. He had some abdominal pain, had been on methadone now for about a week. 40 milligrams daily. I went to IV while he was in the ICU and had available oxycodone as needed that he was not using before I met him. So just a quick timeline, because sometimes people like timelines better than bullet points. Again, just sort of middle of October, he's having this new abdominal pain, sees the mass. About a week, less than a week later, they put in a stent, took brushings, those were not conclusive. After he left the hospital, he did not come to his GI follow-up. Don't know why. But GI rescheduled him just a few days later and started planning for an EUS, an endoscopic ultrasound, to try to get a biopsy that way. And fast forward to end of December, this is when he came in for our admission. So he had this chest and abdominal pain and had actually gained weight, was seen by tox right away, who started methadone for to try to replace his 2 to 3 intranasal fentanyl baggies daily. And he had actually was going to come to our new sort of inpatient unit for that helps people with addiction and psych issues, but was going to leave, and then he started throwing up blood, the intubation extubation situation. And then by the time I met him, he had been NPO every night for 3 days for an IR biopsy. That just kept not happening. And they would say, okay, we're going to hope to get you in. Your weight sheeted, meaning we'll try to get you in between cases. And then by 2 or 3 or 4, they would say, no, we can't get you in today. So we were consulted on a Wednesday. and they tried to see him, and he was pretty furious, which we'll talk a little bit about, not at me, but at just the whole situation, which I can't really blame him for. And we'll talk a little bit about those next few days as well. But that first day with him being NPO, we really didn't talk much. I got to say hello. We kind of exchanged pleasantries. I got him some water, I think. And he was with a friend, luckily was able to have a visitor, even though he was COVID isolated. They were both just really angry about and frustrated about waiting and feeling very scared about, they tell me that this is probably cancer, and why can't they get this biopsy? And is it because of, who I am? Is it because of my addiction? And the next day I was able to see him, and we were more engaged, but at that point, the IR interventional radiology team had said, it's not looking good. It's Thursday. I don't think we're going to fit him in. It'll be next week, if at all. We should, if he's otherwise stable, you can discharge him and we can see him outpatient. So by the time I saw him in the afternoon, he had been told he would be going home at like 6:30 p.m., a few hours after I saw him, and but was willing to talk about things. And so we'll talk about that. In terms of his situation, he knew that this is probably cancer. He hadn't seen pictures of it yet, but he knew that they thought there was a pinhole in his intestines, that there was a hole that was causing this bleed. He knew that they couldn't tell him his options until he got a biopsy, and he knew that the biopsy was delayed. I did show him some pictures of the cancer, which is a little hard to show because it was sort of fuzzy, and pancreatic lesions can be that way, but he was able to see and kind of at least the size of it, which I think brought it home for him a little bit. And he knew actually from previous discussions with different physicians that his prognosis was probably at less than a year, but he really wasn't sure what much more time he could get with treatment, and I really couldn't give him much information either. In terms of values, he was very clear. He said, I don't want to die. Whatever is going to be offered to me, I will try it. But I also don't really know what my options are yet. So we were kind of in a very tricky situation for values. We did talk about his religious beliefs a bit, and it was mostly around his support systems. Plan, as I said, discharge to wait this biopsy and kind of follow up with us outpatient, which was arrived upon after a lot of discussion with toxicology, with the primary team, and with our outpatient team, which I'll talk about. And it was the second day I visited him, and I tried a little bit to make sure that if he had any wishes around his end of life, preferences around code status and things, that we would be able to have that paperwork done before he left. He was very hesitant to fill out anything, and felt like, don't, if there's any kind of way that you can save me, and did not want to designate a healthcare proxy that time. But he also was pretty angry at me because I would have been frustrated and angry too. He had been told at times that I hadn't been told that he was going to go home. So he asked me, when am I going? And I said, I know that would be a question for your main team. And he's like, why don't anyone talk to each other? And why don't you know anything? And I said, I'm so sorry. And he said, stop saying sorry. I said, how would you like me to apologize? And he thought about it actually for a while and said, well, you could say I apologize. So I did, and we kind of mended our bridge there, but it was pretty shaky ground near the end of our visit. So he wasn't really too interested in any kind of advice I had about form filling out. So I think we can pause there. I actually have some prepared questions there, but would like to hear any thoughts, and I'll open up the question and answer.
Yeah, that's great. I had to change audio. Can you hear me?
Yes.
Okay, perfect. Yeah, I'm not sure. I think, we discussed this case. I think one of the pitfalls is, and you had a consult after he'd been 3 days NPO, promised a procedure, probably about the least ideal time to do a consult. And fortunately, you thoroughly reviewed the charts. You're coming in with a lot of information. Still, that's not an easy time to perform a consult. So, one of my considerations is read the chart. I think we've all, as consultants, if you do consult in medicine, and you're trying to get one more consult in or do something quickly and regret walking in the room without having done that. So, there's regulatory concerns that we can talk a little bit about. I know that you addressed regarding the methadone, as I think the primary team really did not appreciate, the nuances in terms of the methadone. What were the limitations if it was primarily for opioid use disorder? What was needed if you used for pain, and how would you set this best up? And it's not something you can do simply call a consultant so they can come and set up prescribing methadone. So I want to again ask Anne-Marie, during those 3 days where this patient is NPO and waiting for a procedure and isolated, he's got I think COVID isolation or exposure at least.
Exposure.
Techniques might be leveraged to at least help them get through that a little bit better, or even just in general?
Well, certainly doing whatever we can to address the isolation, providing an iPad for him to be able to communicate with anyone else, even his cousin out of state. If there are volunteers, I'm not sure if that was going on during the pandemic, the heart of the pandemic. I didn't mention a couple of other mindfulness techniques that can be helpful to just ground someone in their body, and that's the body scan, where you bring attention to various parts of the body, breathe into those areas, and then let go of your attention. And that can be very calming as well, just for, again, to teach him some methods that he can use on his own during that period of time of waiting and the frustration and anger that arises, to be able to calm that.
Yeah, and I think had he stayed a little longer, I think we could have used it. And I think it looks like Rob is going to answer this question in the chat about methadone and hepatic first pass. I believe his IV dose was reduced to half. I can check into that later.
Dr. Bashevitz, did you have any comments here?
I just wanted to remind people, I'm sure our palliative care team is very much aware of this because of the high emotionality that patients can get into when given these diagnoses. But in psychiatry, we call, we might call it staff splitting, when someone is very happy with their primary team, and then all of a sudden Dr. Kenny comes in and wants to, talk about something else, or talk about forms, or whatever it is, and they take that opportunity to to be very angry at Dr. Kenny, for example, and it's something to bear in mind. They're not necessarily angry at you primarily, but they're wanting, they're just needing to lash out at somebody, and so they preserve their relationship with their primary team.
Yeah, I would agree, and I think there was probably a degree of grief in this situation because we got really far into sort of what this might mean for his life, and it was, I think, even though he might have heard it before, he was able to really emotionally respond in that moment, and I was actually pretty surprised that we were able to get there. And not that I don't need to make everyone cry, but I wasn't sure based on our first interaction how much rapport we would get. And so I think near the end, when he was sort of disappointed by me not knowing everything about his plan, I didn't take it personally, but I think I could see why it might be hard. And it actually gave me pause for when we were considering, do we manage his methadone outpatient, thinking about the team at large, and is this person going to, project their frustration onto our staff or my colleagues. So I think I'll move on just because I know we're getting close on time. If my slides will go. So like I said, you know, this is me, a brand new palliative care attending, I think 6 months in at that point, maybe 5. Asked my leadership, mostly Rob, and about can we do this and is it allowed? And I want to, you know, make sure I'm doing the right thing on all accounts. He said sure, and we talked actually a lot with Dr. Wiegand, and adjusted and recommended that the methadone be split into 3 times a day dosing, even though his pain was fairly well controlled on the daily, just to try to augment whatever pain management we could. He did have oxycodone available for 3 days and really hadn't used it. I'm not totally convinced he knew it was available. So I did recommend that they give a short supply, at least through the weekend, so that he could call us again if needed, and bowel management as well as nausea management sent as well. And to kind of conclude a bit, at least this case, you know, he impressed me and he surprised me. He called the very next day. I had given the instructions for him because I didn't know it was late in the day if my office would be open. And he called, and so I had sent a message, and one of our secretaries said, yeah, he already made this appointment. Your worry is not necessary. He's already made an appointment. He'll see you next week. And I noticed that a week after the discharge, we sent him with 7 days of methadone, that he had not yet requested methadone refill. And I was thinking, like, what is going on? Hope that he's okay. And unfortunately, Jim had been brought that morning to the emergency department, had a cardiac arrest. They attempted resuscitation, brought him to the ED, and it kept attempting resuscitation. No ROSC, or return of spontaneous circulation, was obtained, and so he had died that morning. I did reach out to the medical examiner because we do report, the hospital does report any kind of unclear cause of death, and unfortunately this report won't be completed for 7 to 10 months. Though he's said, you know, if it completed sooner than that, you know, I could reach out periodically every few months. So it's very interesting in terms of, I guess interesting, maybe unsatisfying in terms of a lot of questions still around his death. And there was not a clear, you know, sometimes our emergency personnel will kind of write a report that says, oh, found with paraphernalia or found with this around them. And honestly, the only thing on his person which helped identify him was his Bible that had his name in it. And he was right outside where he lived. So it's really impossible to know exactly what happened, and no description of bleeding or things like that that we were worried about. A lot of reasons why he could have died. So I do have a pause there and prepared reflections as well. I know we are very close, maybe a minute away on time. So maybe I'll hand it to Tim.
Yeah, that was a great summary. And I think, you know, one of the you know, more pertinent areas is, you know, as he became clearly diagnosed, his primary diagnosis, he had an opioid use disorder, but really the primary diagnosis is he has acute cancer-related pain. And that is, you know, taking care of that is of primary importance.
Right.
Yes, consideration of, you know, discussion with risk benefit regarding, you know, his opioid use disorder, but, you know, I absolutely, one is able to switch the priorities in terms of the methadone prescription from primary diagnosis of opioid use disorder, maybe dose for pain, but now the focus is pain, and we don't need to refer the patient to an opiate treatment program. I mean, you know, and this gentleman, just, you know, quality of life, getting to the clinic, don't dose for pain, I think really would have been barriers to, you know, having a, you know, dignified passing. And, you know, unfortunately was, you know, found cardiac arrest, and that may have been a very, you know, painless, you know, way of passing. And you know, it will be interesting what the ME report shows, but I think, you know, you're very diligent in prescribing and follow up and, you know, considering risk benefit here. So I don't know, Dr. Horowitz, do you have other thoughts or comments?
Yeah, I mean, this remains controversial, and I think appropriately, you know, we entitled this whole presentation "Who Cares?" and it's not necessarily who cares about these human beings, but sometimes it feels like who cares about these human beings, who has the heart for them, who has the stomach for them, because these are complicated and they're multidimensional in all sorts of ways, and there can be arguments about who is best equipped. So I think we need to think about medical legal liability for sure. We do think, though, that there's good protection in general for those who feel capable of managing pain, opioid use disorder, and end of life care for palliative care taking that over. But that's not unanimous for sure.
Just want to add one last thought, if I could, and that is my working definition of addiction or substance use disorder from having worked in the field at Westfall Associates. And that is to look at this as a ritualized, compulsive comfort seeking. So really those key words of comfort seeking are what people are always trying to medicate or deal with. And when you lose a patient in that way, unexplained potential overdose, there's always some angst and questioning, what else could I have done? But if you come back to that definition, that this is a longstanding ritualized pattern behavior, hopefully you have the support of your team to be able to debrief and process this.
That's a great comment. Thank you. We're essentially out of time, and the slides are available. Dr. Kenny has some really good points and reflections, so you can take a look at that. There's been some real good comments as well. But I always end with a final thought, and this is from Shakespeare. This is from Macbeth, and it is tomorrow and tomorrow and tomorrow creeps in this petty pace from day to day to the last syllable of recorded time. And all of our yesterdays have lighted fools the way to dusty death. Out, out, brief candle, life's but a walking shadow. Poor player that struts and frets his hour upon the stage, and then is heard no more. It is a tale told by an idiot, full of sound and theory, signifying nothing.